Sorry, I'm going to go back to sharing my screen here. And thank you, everybody. I think we're going to get started. We've got a busy night tonight, and I know it can be late. For some of you, especially after a busy work day or day with whatever life responsibilities that you do have. So anyways, just wanted to start things off. My name is Lori Peru. I'm part-time managing director with the Canadian Arthritis Patient Alliance. I also live with juvenile rheumatoid arthritis. So many of these issues like cardiovascular disease and arthritis are a topic very close to my heart. We like to offer webinars like this to bring together experts like Dr. Bindee Kuriya to help educate people with arthritis about things. We know there have been increasing links between these two conditions, but a shortage of guidance on what we can actually do in day-to-day life to try to prevent issues or identify issues when they do come up. But before we get too started, I just wanted to do a brief land acknowledgement and to acknowledge the land that I live, work, and play on is the land or the territory of the Anishinaabe Nation or the Algonquin peoples here to the north, and to the south is the Mohawk of Akwesasne. So you can all just take a moment to yourselves, or if you want to put it in the chat, to reflect on the land that you live and work and play on out of respect to the Indigenous peoples where you are located, because we all come from different parts of the country.
I don't think so.
And so before we get started, I guess I wanted to do a quick poll in terms of what do people actually know about cardiovascular disease and arthritis, and there is no right or wrong answer to this. It's really just to kind of get a sense as to what you know now, and then we're going to run the exact same poll at the end of the webinar to see if we actually help move that in the right direction. So like I said, no pressure if you don't know anything. I'm sure if Dr. Kuriya was answering this, she'd probably say she wrote the book on the topic. So I see she's probably not completed this. I don't see too much more coming in. I will close that in 5 seconds. All right. So, and here are the results. So hopefully everybody sees that right now. You can see that most people would rate themselves sort of in the beginner zone, which is fine. I know these are very crude sort of options, and then the intermediate zone. So I think we all have a lot to learn, and that's great that we're all here together tonight to learn together. So moving on, just a few housekeeping items. So as I noted in the beginning, we'll be recording this webinar and uploading it to the CAPA YouTube channel and website for educational purposes. Like the CAPA website, the webinar is intended for education, information, and communication only. It doesn't constitute medical advice. We'll be asking a few questions to our guest at the end of the presentation. I think for the most part, we'll just let Dr. Kuriya kind of go through, but you are most welcome to, and I'll be prompting you through to add your questions to the chat, or we'll have a designated period at the end where you can lift your hand and ask your questions at that point. So with that, I'd like to, move it right over to Dr. Kuriya, who is our guest speaker for tonight. Dr. Kuriya is a clinician investigator and an assistant professor at the University of Toronto. Dr. Kuriya's clinical expertise and research primarily focuses on outcomes and rheumatoid arthritis. They're passionate about helping spread the word that conditions like rheumatoid arthritis are whole body illnesses and needed to be treated and studied as such. Particularly, she's interested in the interaction of inflammation on mental health, as well as cardiovascular disease. And she's been studying these sorts of things in Canadian observational cohorts like CATCH, or the Canadian Early Arthritis Cohort, and the Ontario Biologics Registry Initiative. And since 2018, she's helped spearhead the University of Toronto cardio room program aimed at cardiovascular disease prevention and inflammatory arthritis. And I feel fortunate that I'm actually part of one of Dr. Kuriya's studies as a participant myself, because it's been like a long-standing question for myself since I've been living with juvenile idiopathic arthritis since I was 14. So I'm actually quite interested in learning more and seeing how my contribution as a participant might help improve our understanding. So with that, I'll pass it over to you, Dr. Kuriya, and you can take it from there.
Well, thank you so much, Lori, for that kind introduction and to the entire CAPA team for inviting me to speak today. I think this is a hugely important topic, but I see that a lot of you are intermediate knowledge experts, so this may be very basic, and I apologize in advance for that. But I'm hoping that we're going to hit some important points and generate a lot of discussion. All right, here are my disclosures. And I'm hoping that we can make this a little bit interactive. I am not that tech savvy, so we have embedded some polls and surveys as part of the presentation. If anybody has ever used Poll Everywhere, if you could just go to this website and enter my name, 639. When the poll questions come up, it'll prompt you on your iPhone or computer to begin. You can also text Bindee Kuriya 639 to the following number, and I believe Lori's going to put the same information in the chat. So what are the objectives over the next 45 minutes or so? We're going to review the link between inflammatory arthritis and risk factors for cardiovascular disease. And I'm really going to be focusing tonight on rheumatoid arthritis. But what I want you to know is that any systemic autoimmune disease, whether it's psoriatic arthritis, lupus, ankylosing spondylitis, or rheumatoid arthritis, all of these conditions carry the same risk for cardiovascular disease. So you can sort of think about these as interchangeably. What I'm going to be focusing on today, of course, is rheumatoid arthritis. We're going to review and understand how select arthritis therapies that you may be familiar with affect the risk of cardiovascular disease. And we're going to discuss strategies to lower your risk of cardiovascular disease. So I'd like to begin with a case. This is quite a common scenario that we see in our clinics, and quite a common scenario that you may be living with or know individuals who live with. At the time that I assessed this patient, she was 55. She'd had rheumatoid arthritis for approximately 10 years, and she had been fairly well controlled on a combination treatment of methotrexate and leflunomide. Again, medications that many of you may be common to you. Unfortunately, like many Canadians suffering through the pandemic, it took quite a toll on her emotionally, physically, and overall her general health. She experienced 4 flares in the first 18 months of the pandemic, and this was mostly because she was quite concerned about the risk of being immunocompromised during a pandemic where the risk of infection was very high. And so she was starting and stopping a lot of her medications to try to lower that risk. She was taking a lot of naproxen, or an anti-inflammatory, to treat these flare symptoms. She resumed smoking after being very, very successful at quitting for a long time, and this was mostly because of the anxiety and stress that she felt during the pandemic. She described getting a racing heart quite often during the pandemic and feeling quite anxious. And unfortunately, because of the lockdowns and the shutdowns during the pandemic, she was not regularly having contact with her primary care physician, or PCP. And I think, just going over this story, and you don't have to answer, but I wonder how much this resonates with all of you. Does this sound familiar? On examination, she was considered obese by body mass index, or a BMI calculation. And this was slightly different than her pre-pandemic weight, which was about 7 kilos less. Her blood pressure in the office is 140/94, which is considered elevated. And on examination, as you know, rheumatologists love to do, we check for swelling in the joints, and she had 5 swollen joints. So she was considered to have active disease and a lot of changes in terms of her blood pressure and her weight. So this is an example of a person who's living with a whole body disease. As Lori said in the introduction, what I'm passionate about is spreading the news that this is a condition that extends beyond the joints. It may be your joints that are swollen and tender and cause stiffness, but rheumatoid arthritis, lupus, psoriatic arthritis, whatever condition you want to call it, is a whole body disease. And I don't expect you to read this very busy figure, but what I want to show you is that cardiac or heart disease is one of those aspects that can be affected by rheumatoid arthritis. And essentially, every single part of your heart can be involved when it comes to rheumatoid arthritis. So we can get inflammation of the heart muscle. This is called the myocardium, which you'll see at the top. You can get inflammation or abnormalities of the heart lining. That's called the pericardium. You can get abnormalities and blockages of the blood vessels, which I think many of us understand. A term that we often use in medicine is atherosclerosis, or blockages of arteries, and that can certainly happen. You can actually get disturbances of how the heart conducts electricity. So heart rhythm disturbances can happen. And we have valves that control the direction of blood flow in our heart, and heart valves can also be affected by the inflammation of rheumatoid arthritis. So when we talk about this term called cardiovascular disease, or CVD, what I mean by that is any aspect of this can be considered CVD. So any abnormalities of the cardiac or heart system is considered cardiovascular disease. So I just wanted to give some definitions because sometimes we throw these terms out loosely. So how common is cardiovascular disease and rheumatoid arthritis? Unfortunately, it's far too common. And, not to be scary, but the reason that we care, it is because it is the most common cause of death among Canadians. Heart and stroke
Hey,
are, oh, can we just make sure everybody's muted, please? Cardiovascular disease is the most common cause of death in Canadians, and it's certainly the most common cause of death in the patients that I see in my clinic and that all of you might be living with. More than half of deaths in rheumatoid arthritis are related to cardiovascular disease. And as I just mentioned, this is not just run-of-the-mill heart attack or stroke. This can be heart failure. So when the muscle of the heart breaks down and cannot pump effectively, this can be rhythm or arrhythmias, such as atrial fibrillation that you may be familiar with. This can be related to hypertension or high blood pressure. And what's even more concerning is a lot of these conditions are often asymptomatic, and our patient population is more at risk for developing sudden cardiac death. The concern is with heart disease is a lot of times the symptoms, especially in women, and our patient population is largely women, and I can see a lot of beautiful female faces on the line tonight. But biologic women are at increased risk in this condition, not only because they're more prone to getting rheumatoid arthritis, but they're also more prone to having some of the symptoms get missed. Why is that? A lot of times chest pain or blockages in the artery in women can present as just nausea or a general unwellness. It's not that crushing, stabbing chest pain that you see on movies and television. Sometimes chest pain can be mistaken for inflammation of the joints because we have small joints in our ribs and along our chest wall. Sometimes patients are not as mobile because of joint deformities, and so a lot of heart disease is only prominent when you are exercising and having to increase blood flow to your heart. So there's a lot of reasons that our patients may be misdiagnosed or may not have obvious symptoms of heart disease. Even more concerning statistic is that there are deaths happening in patients that are younger than 50 years of age. So patients with rheumatoid arthritis are more likely to develop heart disease at younger ages than a patient that doesn't have rheumatoid arthritis. And when we look at sort of big picture numbers, I think a lot of Canadians understand that a condition like diabetes or high blood pressure is an increased risk factor for heart disease. And most of the studies have shown that patients living with rheumatoid arthritis have a risk that is the same as patients living with diabetes. Yet, the public, physicians, and the media generally don't make this comparison. And the question is, why is that? Another important thing to discuss is, in general, the risk seems to be declining or decreasing over time in the Canadian population. So why is that? Well, the good news is we have better ways of detecting heart disease in our patient population. There have been a lot of public health campaigns, for example, to quit smoking, and a lot of emphasis and money has been invested in encouraging Canadians to quit smoking. So the general health of Canadians has improved in terms of some risk factors. And then I also list here the biologic era. So biologics, many of you may be familiar with in rheumatoid arthritis, are very potent medications to get rid of inflammation and treat rheumatoid arthritis. And since their availability in the early 2000s, we've seen a slight decline in cardiovascular deaths due to the use of biologics, which we think is the result of reduction in inflammation. And I'll speak to that more in a moment. Other studies, unfortunately, have shown that despite all of these advances, being able to quit smoking, better medications, better ways of screening for heart disease, there's still a persistent mortality gap. In other words, patients with rheumatoid arthritis are still dying on average earlier than patients without rheumatoid arthritis. And so this is still concerning because despite all of these advancements, we're still seeing, on average, about a reduced life expectancy of anywhere from 5 to 8 years in patients living with rheumatoid arthritis. So, why are you at risk? What is this connection between rheumatoid arthritis and heart disease? So let's try, bear with me, our first poll. I have no idea if it's going to work. Are you guys seeing this?
Yeah, we can see the slide. Oh, we can see it on your poll, Evie. So yes.
Okay, so then the poll will shut down after 20 seconds. So it says, what's the main reason for the higher risk? And you can see that almost everybody who answered the poll says it's whole body inflammation. Now, lack of physical activity certainly is a contributor. Use of certain medications and your genetics do play a role, but you're right. Whole body inflammation is definitely the key driver. So let's go back. And as you all correctly identified, one of the common denominators between heart disease and rheumatoid arthritis is inflammation. So this is a snapshot of what the inside of a swollen or inflamed joint in a person living with rheumatoid arthritis might look like. And there's all these what I call evil humors, all of these bad substances created by an overactive immune system that causes too much inflammation. And all of these molecules of inflammation can essentially erode or destroy the lining of the joint. That's what promotes joint damage. That's what promotes joint swelling. That's what causes the pain and stiffness. Interestingly, if you look at a diseased blood vessel, one that has lots of blockages from atherosclerosis, you'll see all of these same molecules live inside that inflamed blood vessel. So you can see that there's this shared link between inflammation in the joints and inflammation in the blood vessels. And what inflammation in the blood vessels leads to is plaque buildup, so plaque formation, propagation or further building up of plaque. And when there's a lot of plaque, what happens is that's very irritating to the lining of a blood vessel, and little blood clots can form. And when blood clots become big enough, it can cause complete blockage of an artery, and that leads to no blood flow getting to that heart muscle. When there's no blood flow getting to that heart muscle, or no blood flow getting to the parts of the brain, that can result in a heart attack or a stroke, respectively. And this is not news. This was known many, many decades ago that inflammation is the root of many diseases. And this was the cover of Time magazine way back in, I think, 2004 that indicated inflammation is the secret killer, linked to many conditions like heart attacks, like different cancers, like neurological diseases like Alzheimer's. So in general, whatever we can do to get rid of inflammation is going to be really important. And many of you may have visited your rheumatologist or your family physician and have had your inflammation markers checked. There are a variety of different ways we can check for inflammation in the blood. One of them is something called the C-reactive protein, or CRP. And even in patients without rheumatoid arthritis or a rheumatic condition, in the general population, higher levels of these inflammation markers are predictive of who might develop a cardiovascular event. And in fact, if you've had a physical lately, your family physician may have ordered this. And if you've ever had to see a cardiologist, your cardiologist may have ordered this because the C-reactive protein is used as a tool to estimate your overall risk of heart disease. If it's high, your risk is high. If it's low, your risk is low. And what this does is it helps a cardiologist or a family physician determine if further tests are needed to diagnose whether you have heart disease, and or if certain treatments like cholesterol lowering medications or statins are required. So how does this apply in rheumatoid arthritis? Well, in rheumatoid arthritis, we like or want to think of individuals who have been living with a lifetime of inflammation. So the general population may just check their inflammation at one point in time with their annual physical. But in individuals living with rheumatoid arthritis, you've had inflammation for many, many years. And so patients who have had disease for a long time, those who have a deforming disease, such as joint deformities, if you have positive antibodies or markers in your blood, and or if your rheumatoid arthritis affects other parts of your body, like your lungs, or if you have rheumatoid nodules, for example, these are all other risk factors that inflammation is very high in your body and may increase your risk of having heart disease. The other point I want to hit home is, let's say you've had well-controlled disease for the past 2 years. Your risk really depends on how long your inflammation was not well controlled. So this is a study, and I just want to point your attention to the x-axis. So at the bottom, you see on the far left, people without RA here. I'm hoping you can see my mouse. Then people who are in remission, so very minimal tenderness, swelling, joint deformity. Those who have more active disease, and those who are having recurrent flares. And we all know that patients living with rheumatoid arthritis unfortunately do experience flares from time to time, even if they're well controlled. And what this is showing is on the y-axis is your risk for developing heart disease. And you can see that when you have active disease, or even if you have repeated flares, your risk of heart disease goes up. And so what this tells us is that the number of times you have very high inflammation in your body added up over time can increase your risk. In other words, being in remission and being very stable for many, many years is the best chance at lowering your risk of heart disease. And so this supports the concept of tight control, and this supports the concept to do anything you can with therapies, with lifestyle, to minimize how much inflammation your body sees. And the analogy I use is inflammation is like a fire. If you don't put out that fire, it can simmer along and it can damage or destroy things it comes into contact to. And what that can damage is not only the lining of the joints, but the lining of the blood vessels, the lining of the heart muscle itself. So anything you can do to put out that inflammation for good and not let it simmer is going to be protective. And one of the ways that we can get rid of that fire of inflammation, of course, is through the use of disease-modifying anti-rheumatic drugs, or DMARDs. So just going back to the main reason for the higher risk, you guys all appropriately indicated that although some of these other answers are correct, whole body inflammation is one of the key reasons for the higher risk of cardiovascular disease and rheumatoid arthritis. So just to recap this part of the presentation, rheumatoid arthritis is linked with an increased risk of heart disease. We know that unfortunately, a premature or earlier cardiovascular disease happens in our patients at younger ages. It's often asymptomatic, so take any new or changing symptom very seriously. And unfortunately, it's still associated with a higher risk of dying or mortality. Risk factors includes having lots of years of untreated or poorly controlled inflammation, high levels of C-reactive protein or inflammation in the blood, arthritis that extends beyond the joints, such as rheumatoid nodules, and having high antibodies in the blood. And if this is any part of your illness journey, these are reasons to be screened and checked. So how do the rheumatoid arthritis therapies affect cardiovascular risk? And this is a very busy table, but essentially we have very many different types of therapies offered to patients living with rheumatoid arthritis. We have what we call the conventional disease-modifying drugs. Steroids is included in this category, glucocorticoids, but other names that you might be quite familiar with, like methotrexate and leflunomide. You can see in the middle column all of the different types of biologics. So by and large, these are injectable or infusion type medications. And then on the far right are targeted disease-modifying drugs, or JAK inhibitors, that are a relatively newer class of agent. So I don't have time to go over all of these, but I'm going to focus on where we have the most evidence, which is with methotrexate and tumor necrosis inhibitors, or tumor necrosis factor inhibitors. So this is, again, another busy slide. I apologize for that. But basically what I want to share with you is that there was a big review that pulled a lot of different clinical trials together. And they looked at patients who were treated with methotrexate with rheumatoid arthritis compared to patients who were not on methotrexate. So typically another type of disease-modifying drug or nothing at all. And what they looked for is what were these individuals' risk for developing any type of cardiovascular events, so that's CVE. And then they looked at specific types of heart events, so myocardial infarction, which is called a heart attack, heart failure, stroke, or a combination of any of these. And what you can see here is that myocardial infarction or heart attacks were actually reduced by 19%. And the risk of having any cardiovascular event was reduced by 28%. So anything to the left of these little bars is in favor of methotrexate. So very strong evidence that methotrexate in patients with rheumatoid arthritis could lower your risk of heart attack or cardiovascular events. So how does this work? This is the dreaded methotrexate, and I know many of you have a lot of experience with this, and it's a wonderful drug when it works, but it can be a terrible drug for a lot of side effects. And this is something that we're having to communicate every day in clinic, and I really I sympathize with people that have difficulty with methotrexate because it can be a very hard medication to tolerate. But when it works, it can work well, and it can also work well to reduce inflammation in the heart. And what's really interesting is that there have been a number of studies to show that even when you lower inflammation with methotrexate, that's fine and good. But it also does other things at the level of the blood vessels that can reduce the risk of heart disease. So it can improve the lining of blood vessels, making them a little bit more smooth. It can actually get rid of too much cholesterol in the bloodstream. It can reduce the stress and the pressure on blood vessels, and it can make them less stiff so that they're able to deliver blood flow to parts of the heart. And what you see in this picture here is a normal cross-section of an artery here on the left, where there's lots of different layers, but you can see that the inside of the tube is nice and clean. And beside it, you can see a not so nice blood vessel with lots of plaque, with lots of blood cells, with lots of potential clot. And you can imagine if that keeps building and building over time, it's going to completely block that blood vessel. So methotrexate seems to have a direct effect on what's happening in the lining of these blood vessels, independent of its ability to reduce inflammation in the joints. What about our TNF inhibitors? So these were the first biologics that came on the scene in the late 1990s, early 2000s. These are medications like adalimumab and Humira and etanercept and Enbrel, and there's a variety of those available for use now. And similar to the methotrexate story, these biologics reduce the risk of a heart attack by even more, 41%, and reduce the risk of things like stroke by 43%. So the question is, how do these work? Similar to methotrexate, obviously they reduce inflammation and help with joint inflammation, but there's lots of evidence that, again, they work at the level of the plaque to keep it from progressing, and they can make blood vessels less stiff, promoting better blood flow. And I think a really important thing for anybody who has had good success with a biologic, you can probably say that it allowed you to get moving again. And we know it's really important to get moving with physical activity, to be more mobile, to be able to go to work, to have an improved sense of mood and well-being when you hurt less. And all of these are also positive ways to reduce your risk of heart disease. And so I always say in my clinic, when you hurt less, you can do more. And that's what we need our patients to be able to do. When you hurt less, you can do more. And physical activity, I can't emphasize enough how important that is just for general health and overall well-being, but specifically for cardiovascular disease. So even though TNF inhibitors and methotrexate may have direct effects on plaque, it's really difficult to measure how well it makes people move. But this is a big component. So these medications, as sometimes difficult as they are to take and tolerate, are heart protective. That's where I want to start the conversation, is not only are we using a medication to lower the swelling in your joints, but we're using it to lower and get rid of the inflammation in your whole body, and that will also help protect your heart. And it does so by reducing plaque. It does so by improving the structure and the function of our blood vessels. And as I mentioned, it can actually lower clinical events like heart attacks and strokes. And it has been shown to reduce the risk of dying from heart disease. So if that was the end of the story, we could be done and enjoy our Tuesday evening. But unfortunately, inflammation isn't the only part of why patients living with rheumatoid arthritis are at increased risk. So there are what we call traditional risk factors that are also at play. And so let's try again to go to our next poll, if I can. So which of the following is not considered a traditional heart disease risk factor? Okay, so we've got diabetes and hypothyroidism. And I think that's it. Okay. Okay, so let's get out of that. So most people said hypothyroidism is not a risk factor, and a few said diabetes. So let's go over what the correct answer may be. So this was a really nice study that looked across many different countries in the world. It was an international survey of rheumatology practices, and they said, hey, rheumatologists, tell us how many of your patients have different types of illnesses. And they also asked patients, hey, have you ever been diagnosed or treated with the following conditions? And this is just a snapshot of the heart diseases, the cardiovascular diseases, and the cancer. And what I've boxed in the orange are all of the traditional risk factors for heart disease. So you can see high numbers of patients report being smokers. A smaller number, around 13%, report having a family history of heart disease. Very high numbers of people with high blood pressure, 40%. High numbers, 1 in 3 people reporting having high cholesterol, and about 15% reporting a history of diabetes. So those numbers may not be alarming to you, but one thing that we're very, very concerned about is the risk of cancer. And you can see that the risk of cancer is very, very low. And these traditional cardiovascular risk factors are very common or prevalent in our patient population. So what are traditional risk factors? And I like this kind of diagram because it tells us the things that we can control and the things that we can't control. So there's things that you can't change, how old you are, your genetics, your family history, and you can't change your sex that you were born and assigned at birth, okay? So you can't do much to change any of these. But here are the things that you can change. You can definitely change if you have high blood pressure, if you have high blood sugar or diabetes, if you're overweight or obese. You can do something about chronic inflammation. And there are a lot of lifestyle modifications in terms of diet and exercise, smoking, stress reduction, and cholesterol levels. Okay. Some of these are easier to intervene on than others, but these are what we consider modifiable risk factors. And then there's a lot of things that I argue also will play a role. Access to care, whether you even have a physician, a family physician, whether you can travel or afford health care, social isolation and the environment and pollution that you might encounter. These are all important risk factors as well. So my question always is, do you know some of your values? It's really important. I just said there's things that you can change. It's important you know those values in order to make that change. So the challenge with rheumatoid arthritis and any of our chronic conditions, unfortunately, is that a lot of the traditional risk factors are never measured in our patients, or if they are measured, they're undertreated. So let's go over some of these. One is being overweight or obese. And we always think of being really overweight or obese as being a risk factor for heart disease. And that's true, especially if you're carrying weight in your abdominal section. We know that more tummy fat or having a bigger waist is an increased risk factor because the fat and the inflammation in the abdomen can spread to the organs in the abdomen, including the heart. But a lot of patients with rheumatoid arthritis are very, very thin. And that's because of low muscle mass. That's because of poor mobility. That's because a lot of times when you're having very high inflammation, you feel unwell and your body's in a state of breakdown. And just because you're so-called skinny, you can actually have a lot of fat inside your organs that puts you at risk. So there's this concept of being skinny fat, which is not a very nice term, but what it's trying to illustrate is that it doesn't matter what your absolute weight is. If you have low muscle mass, then that's a risk factor for heart disease because you're not very active. Speaking of activity, many of you know all too well when you're having a flare or when you've had long-standing disease and you've had joint replacements or you have a lot of joint deformities, it's hard to be active. It's hard to be active with, lots and lots of pain. It's hard to be active with a lot of deformity. And I just said that physical exercise is so important. So there's strategies that we have to come up with to engage in some form of physical activity that may be conducive to people living with joint damage. What about diabetes? So diabetes is something that is easy to screen for, and it is something that we have a lot of effective therapies for. How are our patients are at increased risk? Well, one is a lot of times patients are on things like prednisone. And prednisone, even if used at low doses, but if for a long period of time, can increase your blood sugar and increase your risk of steroid-induced diabetes. We also know that diabetes comes from people who carry too much tummy weight. So I just said our patients are prone to that. And we also know diabetes can happen in people who are inactive. The other important thing is patients with rheumatoid arthritis, and it's been shown in several studies, are less likely to be screened. And we're going to go into some of the reasons why that happens. So I'd like you to think about the last time you remember having your blood sugar checked and having a conversation with your healthcare provider about being screened for diabetes. What about high blood pressure or hypertension? This is very common. I just showed you about 40% of patients in that international survey said they had hypertension or high blood pressure. We know that, again, it's underdiagnosed, it's undertreated, and a lot of the medications that patients might use for treating pain and stiffness, like non-steroidal anti-inflammatory drugs, raise blood pressure. Corticosteroids or prednisone also raise blood pressure. So again, it behooves me as a rheumatologist, if I hear that you're taking ibuprofen around the clock to treat your pain, we've got to come up with a better strategy because it can increase your risk of having high blood pressure. And similarly, a lot of medications we use can raise your cholesterol. And we also know that when you have a chronic condition like rheumatoid arthritis, you're less likely to have screening for your cholesterol and less likely to be treated for your cholesterol. And then another huge problem is the proportion of our patients who smoke. So still in 2024, it's estimated that about 20% of patients living with rheumatoid arthritis currently smoke. That can be 1 cigarette or 2 cigarettes a day, that can be a pack a day, but active or current smoking is still very common. And unfortunately, cigarette smoking makes everything worse. It makes your risk of heart disease worse. It makes your risk of having a bad rheumatoid arthritis outcome worse. It makes you less likely to respond to disease-modifying drugs. So smoking is one of those things that from all angles, we want to stop. And this is just another schematic. I thought it was a nice way to show that when you look at the risk of cardiovascular disease in rheumatic conditions like rheumatoid arthritis, there are so many different things that are contributing. It's smoking, it's your cholesterol, it's high blood pressure. There's hormonal risk factors that I didn't have time to touch upon. There's the psychosocial factors. There's the family history and the genetics. Again, some things that we can't modify. But there are a lot of things that go into why our patients are above risk for heart disease. So going back to our poll, cigarette smoking, diabetes, high blood pressure, and high cholesterol would all be considered traditional risk factors for heart disease. Hypothyroidism, although it might impact weight gain and it might impact cholesterol indirectly, is not considered a traditional risk factor for heart disease. So when we're talking about traditional risk factors, we're talking about the other ones listed here. So I just mentioned that a lot of our patients aren't getting appropriately screened. So what's the approach? How should you be screened? One is following the Canadian guidelines for blood pressure, diabetes, and cholesterol. There are very well published guidelines that most family physicians use on who to screen, when to screen, how often to screen, and what to do if you get an abnormal result. Okay, so this applies to rheumatoid arthritis too. There's nothing specific about rheumatoid arthritis other than our patients are at high risk and deserve to be screened. But in terms of how they should be screened, it's no different than somebody living without rheumatoid arthritis. It's really important to advocate for yourself. If you have not had your blood pressure, your blood sugar, your weight, and your cholesterol checked at least once a year, please go and do it. And a lot of times people ask us as rheumatologists, because we might be the healthcare provider that you're seeing the most, what is an abnormal blood pressure? My blood pressure is always running at 150 over 90, and I don't have any symptoms, so why do I need to treat it? Any blood pressure repeatedly, more than 2 or 3 times, above 130 over 90 is considered high blood pressure. Any fasting blood sugar more than 7, or another marker called the hemoglobin A1C of more than 6.5% is considered diabetes. And weight, there's no perfect weight cutoff, and of course it differs for every individual, but there are cutoffs for what would be considered overweight or obese, and there may be some strategies and potentially as you've all heard, newer medications to promote weight loss. What about cholesterol? There are very, very clear Canadian guidelines on how to screen for lipids. Lipids is another term that we use for cholesterol. And what I want to draw your attention to is about 4 years ago, these were updated. And the recommendation now is, regardless of how old you are, if you're living with one of those conditions I've highlighted in red, rheumatoid arthritis, lupus, ankylosing spondylitis, HIV, inflammatory bowel disease, regardless of your age, even if you're 24, if you're 74, you should have your cholesterol checked. And this was a big paradigm shift because, personally, I know going to my family doctor, I would ask about my cholesterol, and it wasn't until I hit a certain age would she start checking it. And this is false. If you have one of those chronic conditions I've highlighted, at any age, cholesterol needs to be checked. And one thing I want to go over, and this is a busy slide, kind of full with a lot of medical jargon, I apologize for that, but I want to discuss this interesting phenomenon called the lipid paradox in RA. So I think a lot of people understand that there's good cholesterol, and one of the good cholesterol markers that you can get checked is something called your HDL, or high density lipoprotein. And there's bad cholesterol, low density lipoprotein, or LDL, and total cholesterol, or triglycerides. The thing is, with inflammation, when you have active rheumatoid arthritis, your LDL, that bad cholesterol, can actually look artificially low. So during times of extreme inflammation, what happens is the cholesterol in the blood can look low. And then when you get treated and the inflammation gets better, the cholesterol can rise. So it's really important when to measure your cholesterol. It's the best time is to measure it when your rheumatoid arthritis is controlled, because that will give a more accurate reflection. So many times I've had patients with very, very severe active disease. Their family doctor checks their cholesterol and it's quote unquote normal. But that's not the time to do it. It's the time to do it is when the disease is under better control, because then you might actually see it shoot up and be very high. The other point I want to make is that newer cholesterol tests might be more accurate and less reflective to these changes in inflammation. And it's super important to get your cholesterol checked at least once a year. And as I'm going to talk to you about in a moment, these newer ways of checking cholesterol may be even the better way to do it. And what are these newer ways? This is, again, a schematic showing the inside of a blood vessel, an artery. And what you can see is that all the yellow dots are these cholesterol deposits. And a lot of cholesterol has different makeups. And these newer cholesterols, something called apolipoprotein A, apolipoprotein B, and lipoprotein A, are all much more specific and accurate at predicting cardiovascular risk. They are routinely available. A lot of family physicians are starting to use this as screening. And I encourage you to speak to your family physician about these newer ways of checking your cholesterol that may be more accurate and better reflect your risk. So one of the questions we get asked is, well, then what role do rheumatologists have in helping screen and helping to educate and helping to potentially treat risk factors for heart disease? And this is a loaded question. I, of course, have an interest, so I will sometimes engage in discussions about this with patients. But if you can think about your rheumatologist or a rheumatologist who might be serving a very large area and dealing with very sick patients, it's very challenging to then add this to the plate. But there are a number of recommendations that have been published here in Canada by rheumatologists about at least having the conversation. So some of the themes are, as rheumatologists, we should be discussing that our patients living with rheumatoid arthritis are at higher risk, and insert that in one of your notes to the family physician and see if you can get their help and guidance on how to screen. If your patient is a smoker, encourage them to stop smoking and at least have this conversation every year if they're remaining a smoker. It's important to at least measure a blood pressure once every year. And if the blood pressure is elevated in the rheumatologist's office, don't just, make a note of it and not do anything about it. Relay that information to the primary care physician or another healthcare provider that may be better equipped at managing or treating that high blood pressure. Measure the cholesterol at least once. And what here is the recommendation is, if you're diagnosed with rheumatoid arthritis, Even if you're 21, in that first couple of years of disease, it's really important to check the cholesterol. And remember to do it when inflammation is better controlled. We should be screening for diabetes. We should be counseling our patients about physical activity goals, and we can have a discussion about what are realistic goals. We should be documenting weight in our charts. And as rheumatologists, something that I think we can have a huge impact on is if you are coming into our clinics taking station about how we can wean that prednisone or limit the dose, because this is a huge risk factor for a lot of bad health conditions, weakening of the bones, diabetes, high blood pressure. Another thing that rheumatologists can do very well is limit the use of anti-inflammatory or non-steroidal drugs that can drive up your blood pressure. So some of these things, as a rheumatologist, your rheumatologist may not be comfortable checking for diabetes, but we should definitely be comfortable at least having a conversation about quitting smoking, documenting your weight, checking your blood pressure, promoting exercise, and limiting the use of medications that, while they help with inflammation, can have bad long-term side effects on diabetes and blood pressure. So the last poll, let's go to. So just out of curiosity, how many of you have had your cholesterol and blood pressure checked at least once in the past 12 months? So in the last year, if you're comfortable answering that. Okay, so it looks like the vast majority of you are motivated and hopefully have a lot of good communication with your primary care providers and have had screening. So if all of this is known, if we know inflammation is a risk factor, if we know that having high blood pressure and diabetes and high cholesterol is the issue, why can't we do something about it? And there's been a large body of research done looking at the barriers to this, right? So I like to think of barriers at multiple levels. So one is at the individual level. Some of our patients just have no clue that there was a link between heart disease and rheumatoid arthritis. And that doesn't make them dumb. That doesn't make them stupid. It just means that it wasn't ever discussed and it wasn't ever known. The other issue is a lot of times, as you can all probably attest, when your arthritis is active, that's your main priority. You're not going to then run down the street to get your fasting blood work when you're in a major flare and all you can do is lie in bed because it hurts so bad. Access to care is a big issue, right? What if you don't have a family physician? What if it's during the pandemic and all of the labs and places to go to check your blood pressure were closed? And it takes time. It takes a lot of time to be dealing with multiple health conditions. At the level of physicians, a lot of times, and unfortunate, specialists and family doctors or primary care work in silos. We do our own thing. We rarely talk and communicate together. And another issue is, when they've done surveys of physicians, why are there these barriers? Everybody's a little bit afraid of infringing on that other person's job. If I order cholesterol, will that family physician think I'm being a little too sassy? And, will that ruin any professional relationship? The other thing is in medical school, yes, we get taught all of this, but as you become more specialized as a rheumatologist, you focus on the rheumatology and we forget the newest guidelines for high blood pressure and diabetes. So the lack of training and expertise in that area may prevent some rheumatologists from taking the lead or taking charge of this part of your health. And of course, time and resources face all healthcare providers. And at the level of the healthcare system, we're designed in Canada for kind of one issue, one visit, right? Family physicians are really strained and stretched for time. And a lot of times you might go in with a list of things you want to discuss, but you only have 5 minutes and it's only one thing today. And unfortunately, North American society still focuses on acute care, dealing with the problems. We're reactive as opposed to focusing on prevention. So I think there's a lot of reasons why we're not optimizing our care. And so the question is, can we do things to improve cardiovascular risk care? And you can see that it's not so simple. There's lots of things that we have to take into consideration. You have to get the RA under control. You have to minimize prednisone. You have to treat the cholesterol if it's high. You have to treat the blood pressure if it's high. We have to stop smoking. It's really challenging to do all of that at one visit, let alone two visits, right? So how do we break down these barriers? I think the answer lies in empowerment, in education, and coordination of care. And I don't have time to discuss what Lori alluded to at the beginning in the intro of coming up with newer models of care. And I'm very fortunate at the University of Toronto to be part of a cardio-rheumatology program where we put the minds of rheumatologists and cardiologists together, and our patients are able to see both of us and determine who's going to take charge of treating what aspect of your health. And so coordination of care and expertise is really, really important. The other thing is we need all of our patients to understand the risk, and we need you to advocate for yourself. So here's kind of a basic 101 on what you can do to lower your risk. And again, many of this may be very obvious to a very highly engaged and interested and educated group of people like yourselves. But I really encourage you to know your blood pressure. Don't just have it checked, but make sure you know what those values are, and don't settle for a high blood pressure. Family physicians or a nurse practitioner, or even when you go to Shoppers Drug Mart, it might say normal on the screen, but ask, is that normal for someone living with a chronic condition? Is that normal for someone of my age? Is that normal for me with a family history in my mother or father of having a heart attack or stroke? Know your blood cholesterol and make sure that you're being screened for diabetes or blood sugar. Inquire about newer ways to measure cholesterol. Hey doc, I understand that there's different ways of checking cholesterol, some that may be less influenced by inflammation. Do you know anything about that? Is that something I'm eligible for? If you have these conditions, be very stringent about managing diabetes, taking your blood pressure medications. I mean, I'm preaching to the choir here, I know, but it's really important that these are lifelong conditions. They don't usually get better just with lifestyle. A lot of people can lower their medication, the number of pills they take for blood pressure, for example, by losing weight and exercising. And some patients are actually successful at getting off all blood pressure medications. But things like diabetes rarely go away just with lifestyle, especially if it's a more severe form of diabetes. And emphasizing to be smoke-free. Another thing that we can do is obviously maintain a healthy weight, be physically active. Question that I get all the time is, what's the best diet for someone with rheumatoid arthritis? And I apologize, I don't mean to gloss over any of these big concepts, but it's a talk in of itself, and I'm happy to come back. But an anti-inflammatory diet is something that a lot of people are seeking. And I always say there's no perfect anti-inflammatory diet, because if there was, we'd all be doing it. But when it comes to heart healthy diet, the one that has the most backing and the most scientific evidence is a Mediterranean diet. So one that has a lot of healthy fats from fish and olives and avocados, nuts, whole grains, and lean protein. Okay. Another thing that's an important lifestyle factor is to limit alcohol consumption. Increasingly, we're seeing that even 1 or 2 drinks a day is associated with a lot of negative health consequences, including cardiovascular disease. So the mantra of 1 glass of red wine a day was heart protective is kind of up in the air these days. But I think with anything, moderation is key. And much easier said than done is to reduce the level of stress. But these are all general health measures that are good for you, but also lower your risk of heart disease and can improve your rheumatoid arthritis. So the last concept is know and treat your rheumatoid arthritis aggressively. So we know that this root of chronic inflammation can increase your risk of bad things. So it's really important to have tight control of your disease. This may require the use of disease-modifying drugs, biologics, or other targeted therapies for life. And one thing that is really important, and why I love what I do, is it requires frequent evaluations. You got to see your rheumatologist frequently to make sure that you're staying on track. Of course, a lot of patients are in remission and doing very well, and you can space out those visits. But what I really enjoy about being part of a team with people that are living with rheumatoid arthritis is that you get to really follow each other and form relationships over the long term. So thinking about our case, this was a woman who was not doing so well in the pandemic. I highlight here in red a lot of the risk factors that we just described for heart disease. Having long disease duration, she's had rheumatoid arthritis for 10 years. She's having recurrent flares. I forgot to mention here that she's taking naproxen, so she's taking a non-steroidal anti-inflammatory drug quite regularly to treat her symptoms. She's resumed smoking to cope with all of the stress. She's not been screened, and she has a lot of risk factors. So she's overweight, she has high blood pressure, and her disease is active. So you can see that in this one patient, just with one snapshot at one clinical visit, there is a lot here to unpack. And so, overall, what should be done for an individual like this? All of the following. And again, this is not going to be done at one visit. This can even potentially be done at 5 visits. And I don't think it can be done by one physician. And this is where this concept of coordinated care with family physicians, cardiologists, rheumatologists is going to be really, really important. So, to summarize, that was a whirlwind tour, but cardiovascular disease is still the #1 killer of people living with rheumatoid arthritis, as it is in the Canadian population. Inflammation is a key risk factor, it's a key driver. So, anything we can do to control inflammation is going to be protective. By lowering inflammation through the use of disease modifying drugs and biologics, we can actually protect and reduce the risk of heart disease. And it's really important to understand what those traditional cardiovascular risk factors are. They're more common in people living with rheumatoid arthritis. They're unfortunately still too commonly underdiagnosed and they're undertreated. So anything you can do to advocate for those is going to be really important. And just to conclude, I really think we need to bridge this gap. It's going to take work. We're making some strides. But in order to treat lifestyle and to control disease and to screen and treat risk factors, it really takes a team. And so I'm hoping that some of our politicians and our healthcare system will acknowledge that even though this is a disease that affects the joints, it is a whole person disease, and we need a team to treat that whole person. So with that, I will stop here, and I'm happy to take any questions. I'm sure there's lots of comments and discussion. I'd be interested to hear your thoughts.
Yeah, no, thank you so much, Dr. Kuriya. That was a lot of territory to cover, and we
Yeah.
very much appreciate it. Almost like you could take all of that and develop a tip sheet, like, or a pretty comprehensive resource for patients to face some of these questions and that. So we do have a few questions that were in the chat, so I'm going to start with that, and then of course I have a few of my own to back things up. But I guess the first one that came up was someone asking about, how do we actually have that conversation, either with the rheumatologist, because you talk about the family physician or primary care. I guess that could be a nurse practitioner. And about the cardiovascular risk, now that they've been kind of here and listening to you. I don't know if you have any, like, how do you start that conversation, I guess?
Yeah, I mean, I think, what's a little bit frustrating and challenging is they've kind of gone away with the annual health exam, right? So the opportunities that many of us had to book a once a year check-in with our family physician and do a physical exam is kind of been debunked. There's a less emphasis on actually doing a physical exam, more emphasis on just focusing on asking about risk factors and then doing blood tests and other tests to evaluate for that. So that's not necessarily wrong, but I would definitely say I have rheumatoid arthritis. This condition puts me at higher risk for heart disease. I don't recall when I last had my risk factors checked. Can we have a discussion about that? And I don't think any family physician would scoff at that. And it might be done in parts, but you can check for cholesterol and you can check for diabetes with blood tests. And at one visit, you could check your height, your weight, and your blood pressure. And you could ask about smoking. So all of those risk factors are done right there, those traditional risk factors. What we're doing as rheumatologists also is indicating in our notes, especially when we're making a new diagnosis of rheumatoid arthritis, is, patient MI has been diagnosed with rheumatoid arthritis. This is our plan. And by the way, she's at increased risk of heart disease because of this condition. Can we please work together as a team to make sure X, Y, and Z are checked? Sometimes that happens, sometimes it does not. But I always tell the patient, I'm going to be communicating this to your family physician. Are you able to follow up? Where we need to do a better job, and I do too, is in the follow-ups. When you've had disease for 5, 10 years, making sure that little blurb still finds its way to the family physicians. It's not just when you make a new diagnosis, and it's not just when you're doing poorly, it's all along the way. Um, so I don't have a perfect answer for you for
Yeah,
that.
but that's
But
good.
I think just, I think just being an advocate for yourself. And I think the important thing is for our younger patients, and especially our female patients living with rheumatoid arthritis, they're the patient population that tends to get neglected the most. A lot of
Yes.
people understand that a 68-year-old man who smokes, oh, that's kind of a risk factor for heart disease, but people don't equate a 33-year-old woman with really bad RA as being that same risk.
Right, right. I know. And I've had those conversations myself, but I just wondered if you had any particular advice. And I think that's helpful, right? With some of the tests that you noted on one of the slides. And so definitely some good advice there. I know someone else too had mentioned, because I mean we've all taken, I've taken prednisone like more times than I really want to have ever thought of, frankly. And just wondered if you've been off of it for a while, like someone mentioned, they've tapered off of it for say 15 years, does that still increase your risk kind of down the road because you've taken so much, for example, at an earlier part of your life?
Yeah.
Or
So a couple of things with that. One is a lot of people have researched what is the dose of prednisone that carries the highest risk. And the bottom line is anything more than 5 milligrams for more than 3 months is bad. Okay. And that's just 5 milligrams for more than 3 months, because that can increase risk of osteoporosis or thinning of the bones, diabetes, high blood pressure. And now we know heart disease. Now, being on prednisone at 6 milligrams for 3 months is very different than being on 10 milligrams for 10 years. So it depends on the duration that you were on it. So even if you were off of it for 15 years, yes, that's great. But if you were on prednisone at a high dose for 20 years before that, that's bad. So I don't have a great way to answer that question. But presumably, if you've been off prednisone for 15 years, that means your disease is well better, way better controlled. And that's great news. But the damage may have already been done in that early phase when you were requiring very high doses of prednisone. So it's that cumulative inflammation that you've had over a lifetime that becomes very, very important. And when you're speaking to your rheumatologist, if I get a story, let's say I'm just picking out of the hat. Let's say you're 55, and from the ages of 25 to 45, you had terrible disease, cycling through lots of different medications, lots of flares. I would say even if you're great now, even if you're in remission, no swollen joints, low inflammation, you're at high risk and we need to screen you for such. And I glossed over, there's lots of different ways to check for heart disease. I didn't get into the types of ways we can image your heart, ultrasound of your heart, looking at the inside of the blood vessels for plaque. Those are all tests that can be offered for a person who has a history like that, where even though right now at time point A, you look really good, back then you might have been very bad.
yeah, I know, good to know. And that applies actually to a lot of different kinds of inflammatory arthritis. It seems to be the default drug of choice, right? For if you've
Yep,
got
yep,
lupus or
yep.
different kinds of vasculitis as well. I just wondered, because I know you're mostly focused here on inflammatory arthritis, but I can imagine you could probably do a presentation just on vasculitis or something. But do a lot of these same principles at least,
Yeah,
apply, or
yeah,
or is the
absolutely,
advice,
absolutely. Any chronic autoimmune disease that causes too much inflammation to course through the body, whether it lands in the blood vessel like vasculitis, in the skin with psoriasis, in the joints like rheumatoid arthritis, even conditions like inflammatory bowel disease, all of those patients are at increased risk of cardiovascular disease. And all of those patients, which is why a lot of our Canadian guidelines list those conditions as being high risk and should be screened for things like high cholesterol.
right?
So
Okay.
yes, we think of them interchangeably. In terms of the rheumatology world, most of the study and most of the science comes from rheumatoid arthritis just because it's the most common type of inflammatory arthritis.
Right, right. No, makes sense. Okay, thank you for that. Also have another question from someone, and maybe we'll take like a few more. I know it's getting
Sure,
late, but
absolutely,
if you don't mind
absolutely.
sticking around. There was a question just about, and I know I've kind of experienced this because I've lived with, inflammatory arthritis for most of my life, but the flares, right? And having like is so concerning about the flares, and I know like our thinking has evolved over time, but someone's asking, just what is that kind of showing, I guess, and what
Yeah.
are the implications of that, I guess, on the
Yeah. So kind of like
cardiovascular disease.
yeah, like the prednisone question, there's no safe number of flares.
Right.
But flares that are, in general, I say more than sort of 3 flares in a year is indicative of disease that's not well controlled.
Okay.
Everybody's experienced a flare after maybe an illness, some stress, a vaccine, perhaps, some change in health. And by definition, I always say a flare is temporary. It gets, there's symptoms, and then you do something, whether it's rest, an anti-inflammatory, a low dose of prednisone, and then it gets better. And then you should go back down to where you were. If you develop a flare and then your pain and symptoms are up here and never go back down, that's not a flare. That's your disease ratcheting up. And so that's really important to differentiate. But if it's truly a flare, it's temporary, it's transient, you get better, you go back to your usual state of health. I would be worried about more than 3 flares a year, especially if you're needing medications to treat those flares. So
Mm.
if that is happening, you really need to consider speaking to your rheumatologist about strategies, A, to limit flares. Maybe something needs to be changed. And the other thing is it truly a flare or is your disease changing? Is it reaching another level? And you need to consider altering the therapy that way.
Right. No, I think that's good too, especially for some that are new and just don't necessarily understand all these. But even for someone like myself who's lived with it, right? I've lived with a lot more tolerance for disease activity
That's right.
than what somebody these days, what a rheumatologist would sort of be satisfied with, I guess I would say. But another question too is around, do you know of any resources or places that, to learn more about this issue, or is there not really a lot of resources out there?
No, 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 absolutely. I mean, I think
Mm.
one is the Heart and Stroke Foundation of Canada. And that's something that's easy. I think it's heartandstroke.ca. Of course, the Arthritis Society. I was fortunate enough to be part of a little piece that we wrote on cardiovascular disease and inflammatory arthritis. A lot of the principles that we highlighted here about what you can do to lower your risk. Um, and of course, the individual societies that deal with diabetes and high blood pressure, Canadian Diabetes Association. And then I think, one thing that's really lacking though, because patients always want to know about diet and exercise. I don't have a wonderful resource because when you go to the Heart and Stroke Foundation, for example, they talk about the Canadian recommendations for exercise, which is a whopping number of 150 minutes of vigorous exercise a week. I mean, I consider myself an active person and I don't meet that. It's very difficult for someone with a chronic illness with lots of pain and stiffness to meet that. So it's geared towards different patient populations. So I'd like to see more on the Arthritis Society. And I mean, I think they have refreshed some of that information, but Arthritis Society is a great resource. And I think speak to your rheumatologist and speak to other patients because I learn a ton about resource management from all of you. Are there good websites that teach you about anti-inflammatory foods? Are there good ones to talk about how to maybe lower your cholesterol with the use of diet and lifestyle, and how does that interact with the methotrexate you may take, right? So, I'm sure Kappa probably has amassed a great list of resources, but if that's the case, and I think also it should be shared with healthcare providers because we're kind of sometimes in the dark when it comes to newer resources that are really targeted for patients.
Right, sounds good. No, I think it's a lot of great, places to start there, but that's for sure. And then one last question, I think, before we'll kind of move on to our annual general meeting, and folks are welcome to sort of stay on. But just again, maybe like a very practical one. You talked about how, as a rheumatologist, you try to connect, the rheumatic disease with the primary care provider. But is there anything that could be done, say, more on the patient side to, like, maybe help nudge them, in the
Yeah,
right direction and enable that
yeah. Well, if
connection?
you're fortunate enough to have a care team, right? Because that's a big problem. So, I mean, I wish I could solve the shortage of family physicians and access to care issue. Um, there's no easy fix for that. But the other is, when I mention in my note, whether that actually fax gets through, whether that gets read, whether that's, put in the to-do pile. I think it's really important. And I know speaking to some family physicians, what they appreciate more rather than being told next, you need to screen Lori's cholesterol and her blood pressure the next time she's in. They like saying, Lori and I have discussed her risk is elevated. I have encouraged Lori to book an appointment with you to discuss this. So part of the responsibility lies with the patient, right? And the responsibility can't lie with you if you've never been told that you're at risk. You've never been told that these are the steps that need to be taken to check for your risk of heart disease. But if that has happened and you're a motivated individual and you have a family physician or another healthcare provider, whether it's a nurse or, some people are using different kind of care models now, be empowered to then book that appointment. Now, a lot of pushback I get is, well, it takes 6 months to get in to see so and so. Well, you know, it's better than not getting screened, right? And some rheumatologists are actually very comfortable doing all of this themselves. That's a discussion you may have with your rheumatologist. In general, I'd say a lot of rheumatologists are a little bit skittish because we're not as up to date as family physicians or other healthcare providers about if you find an abnormality, how to treat, right? But some are. So you can always have that discussion with your rheumatologist.
All right. No, it's good. It's good. So
And
it's
last plug is also be referred to a cardiologist if you're concerned. We're very, very the cardiologists are very happy to accept referrals to assess for heart disease. They don't just see people who've had a heart attack or have had a stroke or who have an arrhythmia. A lot of what general cardiologists do is screen for heart disease. This is their bread and butter. And they are beginning, and a lot of them understand that our patients are at high risk, just like a patient with diabetes. And so it's a very easy consultation for them. They're happy to see patients. But what they're noticing is we're not referring. So the
mm,
rheumatologist can refer, your family physician can refer. There's a big gap there in us referring to them because I think we're all a little bit afraid of, oh, are they going to laugh at us because we're sending? No, I've spoken to a lot of them. They recognize they're using measures of inflammation to diagnose heart disease in their own population, so they understand that inflammation with a chronic condition like RA is a risk factor, and I think it's a totally appropriate reason to send their way.
all right. No, it's good to know. And it's good to see that there's growing awareness. I'm glad you highlighted those guidelines on screening at any age,
That's right.
because there was a time I know in the not so distant past that wasn't there for us. So it's always something that you can kind of rely on and maybe show your family doctor is as part of the explanation about, hey, I'm at increased risks and I'm kind of worried about this. So
Right.
it
Right.
gives you a little more backup, I think, sometimes
Yeah,
when
I
you're
think,
having
I think
those.
there needs to be a shift, and it started. It started. A lot
Yeah.
of family physicians are excellent. I don't mean to poo-poo on family docs for not doing it. They're wonderful. They're overstretched. They're overworked, and there's lots of problems with our healthcare system, which is why I really want to empower patients themselves to have that discussion. Because what the family physician might prioritize at a visit is going to be potentially very different from what you want to prioritize, and so you have to have that communication.
Yeah, for sure. No, and thank you so much, Dr. Kuriya. It's been great to hear everything that's going on and some positive news about some of the actionable things that we can actually do to raise those questions with our healthcare providers, with our rheumatologists, the specific tests that we should be aware of. And so thank you for that. And with that, I'm going to launch our final poll and see how everybody. I'm just going to relaunch. So you can, rate your knowledge of cardiovascular disease and arthritis. So feel free to do that over the next few seconds. Oh, I have to say, just by looking at this, I see some significant movement towards the intermediate. Like it was it was much smaller at the beginning, the intermediate levels there. So I'm going
Well,
to
and you
end
know
the
what I
polling.
what I find, Lori, is again, a really motivated, interested group like yourselves. Generally, there's a knowledge, right? There's an interest in research, there's an interest in advocacy. Otherwise, you probably wouldn't be on the CAP website and know about this. And
Mm.
but it's the rest of the patient population who just are, especially if you're newly diagnosed or don't have a lot of access to care or live in remote areas. It's astounding. It's astounding how much inflammation and disease can be in these people. So if you have friends, relatives, colleagues, coworkers that have rheumatoid arthritis, just spread the message, because it's still alarming how many people don't know that inflammation puts their body at risk for other things. So as a community, we need to do a better job of just spreading the word.
Yeah, for sure. And I think it's something for us to maybe take forward in 2025 and share on our different, communication channels and that too. And at least now we have something to refer people to learn a little more. So thank you so much. And